Okay, go ahead, Naga.
Okay. So, I wanted to present about all the efforts that the Texas Child Mental Health Care Consortium has provided. Anybody has sound on? Can we?
You just getting the delay on the live.
Right.
So are we live streamed now?
Yeah, it sounds like the live stream is working now.
Okay,
Okay.
so let's go ahead and then we'll go to the phone.
Okay, so let me talk about the Texas Child Mental Health Care Consortium has offered to support the relief efforts for the flood that occurred on the early July, and we went ahead and contacted the Health and Human Service Commission to find out if there's any way that the consortium can help with some supports. We have met with the Health and Human Service Commission and Hill Country Health and Developmental Disabilities, which is the local mental health authority in the Hill Country area. And they identified 3 needs. Those 3 needs included having some staff that report to Kerrville on a weekly basis in order to help with support to Hill Country. Those supports would be done Monday through Thursday in order to help them with staff and their families with trauma and emotional support. Assisting with providing trauma and emotional support to anybody who arrives at an emotional support center that Hill Country had established on site. And then on the second week that we started, leading a debrief meeting. So Hill Country had other sister LMHAs come over to help support their staff side by side. And the following week after they completed a full week of support, our staff helped with a debrief process in order to kind of assist Hill Country. Trying to navigate on this. So we reached out and asked if there are any folks that could potentially go on site. And we asked all the HRIs. They responded extremely quickly. We wanted to cover 6 weeks. And we so far have had 3 weeks of complete support. Today is the end of the 3rd week. Health and Human Service Commission also had asked us to provide daily information about the number of people served, and we have been doing check-in meetings every Friday. So the outgoing team, so from that week, debriefs with the incoming team from the following week. And through that, we've been better able to organize and make sure. We also have, and I really, really want to thank Dr. Kelly Sopchak. She's the director of TChat at UT Health Science Center, San Antonio. She's been amazing, providing leadership, being there every week, and making sure that the team is organized and supported, and making sure to check in with Hill Country to make sure that everything's moving along. All support is coordinated with HHSC and Hill Country. We just met with HHSC yesterday. We've been in communication with Hill Country to make sure that we're meeting their needs, and as things change, if there are anything else that they need. These are the numbers that we have as far as number of adults, number of LMHA staff, number of children who've been served, and then the debriefs happen every Monday. So you could see that, and each debrief has 10 staff from a sister LMHA. These are some quotes from our staff, and basically letting us know that the situation that they've seen, that there are a lot of needs, that the staff of Hill Country have been working tirelessly throughout this process. They themselves are situated there locally, and so they have been impacted by the flood, and with neighbors and friends and et cetera. And so it's been really heartening for them to be working side by side with the staff of Hill Country. And then the other thing is they've been going to not just Kerr County, but the surrounding counties, which actually have more, some of them have a higher impact to their infrastructure. So they've provided support. This is the feedback we just got from Hill Country. They wanted to basically express how appreciative they are. They did highlight Kelly's really leadership and her support to the process. So I'll leave you with this, and I don't know, Dr. Lake, do you have additional comment?
Well, I guess first, thanks to everybody that jumped in to help out. You know, obviously a terrible situation. Our hearts go out to everybody that was impacted. You know, we think it's important in these type of events to fold into the overall state plan and not be lone actors in trying to jump in. And I think that's where the consortium has been, I think, effective in partnering with HHSC. What we called, again, kudos to Chance Freeman, you know, and his overall management of the mental health needs following the disaster. And we go and try to make sure that if they identify ways that we can be helpful, that we plug into that system. And we use that during Uvalde. We've used that here. It seems to be an effective way of, again, supporting the local mental health authority and having them out front and that filling in the gaps that are needed. And so, again, thanks to everyone that was part of that. Any questions? Yeah. Trina, I saw your hands up.
Yes, no question, but I just gonna say something similar and just say thank you to you, Dr. Lakey, for reaching out and being so thoughtful in your outreach to coordinate and to plug in, allowing us to take the lead. As you guys know, disasters are very overwhelming. Mm-hmm. And so for people who are on the front line, you know, I know when Chance and his team deploy, I still to say to just kind of helping them with air traffic control and getting out of the way so that they can be boots on the ground. When they're overwhelmed with a ton of resources, they then have to engage in trying to navigate the incoming that comes in. And so when partners all to coordinate with us, like you did, Dr. Lakey, it's very helpful in making sure that we can be as effective and succinct in our process in as much as you can be in a disaster. Yeah. So thank you to you, Nagala, for the outreach. Also, thank you for anybody here who sent teams and participated in supporting the efforts there, because as y'all know, the first responder health, right, has been such a focal point. It really became a significant focal point during the pandemic. And then to Dr. Lakey's point, when there was a response in Uvalde, the TCMHCC showed up there too and provided great support and coordination with boots on the ground in that event. And this event is reminiscent of that in a different way, but still with a significant loss and such. So appreciate all, Dr. Lakey, that you and the TCMHCC has done. Thank you.
Yeah, thanks, Trina. You know, as I noted earlier, I think it really is important in these disasters that we don't add to the chaos in the midst of the event. And having been at the state before, Department of State Health Services, that happens with a lot of people that are very well-meaning who want to descend and provide support, but you have to have a way to make sure that the people coming know what their role is and plug into the system. And so kind of this strategy of folding into the disaster mental health plan for the state. And, you know, the institutions put down their institutional flags, and, you know, people won't necessarily know one institution that was there versus another. The face of the disaster of mental health is the local mental health authority. But, you know, what we can do to make sure that they are bolstered in a way that they can be effective, I think really adds to the overall response. to the event. So again, thank you, Trina, for your leadership, and to Chance. I know he's been very busy, and we really appreciate all his experience in disaster mental health for the state. Any questions? All right. We are now live streaming. For those that have joined us for live streaming, we had some technical difficulties this morning, and we've changed rooms and had a delay, but things will be a little bit different in this meeting as we kind of adjust. But we're flexible, and we'll make this meeting work. But again, I want to apologize to those that were delayed in joining us. With that, one item of business that we have to do is every 2 years, the presiding officer is, we have nominations and a selection of the presiding officers. It's been my privilege to be the presiding officer, but it's open to other individuals. And I'm going to hand off the selection process and election to Nagla. Nagla?
So we received nominations for the presiding officers, and the only nominated member that was identified has been Dr. David Lakey. And so I want to put it up for a vote, whether you would like to support the nominee or identify any additional nominees at this
I
time.
move for Dr. Lakey to continue in this role. He's been exemplary.
Second.
I will second.
Okay, and does everybody else agree or say yay?
Yeah.
Yay.
Anybody disagree? Okay, so moved. Thank you.
All right.
Congratulations.
Thank you, Charlie. All right. Well, thanks everybody for your continued support. It is a privilege to be part of the consortium and be part of the great work that you're doing. So again, appreciate the opportunity to serve in this role. With that, why don't we go ahead and move on? Legislative update. We're going to be brief today because of time and catching up. And actually, Andy, at some point, I've seen some of the information that Meadows has put out related to the legislative session, which I thought was really comprehensive. And so maybe at a subsequent meeting, we can have either Nelson or you present some of that work, but that gives a better picture of overall mental health investments by the state. And the bottom line is that the state has invested significantly in improving the mental health system in the state of Texas now for over a decade, whether it's the consortium, rebuilding the hospitals, the missed treatments that have been, teams that have been expanded, et cetera. But Andy, I might, at a subsequent meeting, have you present that overall. I see the thumbs up from Andy. Related to the consortium, we're going to be, again, very brief, but there are some specific things that the legislature has related to us. We're going to talk about the budget in a high level, and I'll talk about why we're going to do that in a little bit. But there were some other specific legislation related to the consortium that I just want to make sure that people are aware of and make sure that you know that we're moving forward on this. Rachel has been taking the lead and making sure we are coordinated in the overall approach. And Rachel, I'll just kind of go through it very quickly, then hand off over to you. But there's 3 big things that the consortium will be doing per the direction of the legislature. First, there is a rider on our budget that says that we're supposed to do an analysis about how we could bill for some of the TChat services. And so we will be exploring third-party billing. That'll be a lot of work as we figure out what is possible in that arena. And so just be aware that there'll be questions as we move forward of figuring out what that could look like, what are the possibilities, what are the challenges, if indeed we try to bill for TChat services after that 5th service. Second one, House Bill 6 will require the consortium to post its referral sources and vetting processes for those referral sources on our website. We'll also be required to for specific data to be included in our biennial report to the legislature related to the referral sources. Again, Rachel has put all this in a program management document that we are finalizing, and then we'll be vetting to make sure we meet timelines to move forward. And likewise, has developed a the plan related to House Bill 18. House Bill 18, we've talked about. It is an overall bill to support rural hospitals throughout the state, and they would like to leverage our CPAN, PeriPAN, and TCHAT services to support rural hospitals, the people that they serve. I think the easier lift is with CPAN and PeriPAN. We already provide a lot of those services to those communities already. The more detailed plan will be with TCHAT, and so we are figuring out who those key stakeholders are. We'll be pulling them together in a meeting, figuring out where we can pilot and then expand quickly. But a tremendous opportunity to expand our services. And the legislature put in $10 million for us to be able to provide those services to rural communities across the state. Rachel, what did I forget? Anything that you want to add? Nope. Rachel says that I've covered it. Andy, I see your hand. Dr. Keller?
Yeah, I just wanted to say one quick thing that, to keep in mind that on the rural health piece, there's also going to be the 5-year process through the One Big Beautiful Bill that put aside the money for rural health that includes hospitals, but it also includes community mental health. And that was a big CCBHCs are included in there. And so that's going to be something I think is going to be really important to think through. How when the state puts that plan together that's due on December 31st, it'll basically be $100 million a year for Texas. And of course, the hospitals are the priority, but it also includes the larger rural infrastructure. So I think everybody just should be aware of that and think about how what we're going to be doing fits into that.
Very good. And Andy, since I've already tagged you to present at the next meeting related to Meadows, related to the variety of things that came in the legislature, maybe we can dovetail into that some of the other national things that are occurring that are so impactful to the state of Texas. Does that seem good?
Yeah, and then I think Commissioner Ito, we should talk if you can kind of help us figure out who is best from HHSC, because HHSC will be heading that up, and we want to make sure that we're supporting that. It's just there's a lot of moving parts, but we'll lay out some of the other federal stuff, and there are some good things. I mean, I think sometimes the language and the way things are framed and the way they filter out can be concerning, but there are some really good things around crisis supports and some other things coming out. So we'll happy to do that.
All right, sounds good. Trina, anything that you want to add?
Nothing I can think of at this time. I think Dr. Keller's right. And I'll work to identify who all should be participating in that conversation. I imagine my area and then perhaps some folks in Medicaid, based on some recent conversations you and I have had, Dr. Keller.
All right, sounds good. All right. The next item related to the legislative session is the budget. And let me give just a little bit of background and let you know why I'm going to be a little bit high level today related to the budget. We talked in the previous meetings that our budget is complex. There are basically 3 components of our budget moving forward after this legislative session. We have the base bill that had about $280 million put in for the variety of services. We also have ARPA funds that are being carried forward and be available. But we also had about $87 million of carry forward that will be very important for us over the next biennium. And as I say that, it really is important. And so it's important that we don't spend down those dollars for other things right now that aren't essential services, because those are the dollars that we need in order to finish the biennium completely. And so when you put all that together, there's about $390 million that will support your work across the state of Texas. One of the challenges is that the UB, the legislation on that is it's not very granular. It just says that we have UB authority. And we want to be very transparent to the legislature about how we're using those dollars. And so we've put together a letter to the LBB to let them know of what our understanding of legislative intent is, what our understanding of how we believe those dollars should be used. We've had some discussions with them. And because of some people being out of town and vacation, they asked for some additional time to approve that plan. But we put in the plan related to all the ARPA projects and the dollars that we would allocate to those plans. We have included in that the additional dollars for research, the YAM project, the collaborative managed care, all those things are in that document that we've provided. We've provided additional some details to the legislature, but because some people are out of town, that timeline for them to finish their review, it ends next week. And so I have to wait for that before I can say this is the verified, approved plan from Senate Finance, House Appropriations, et cetera. And so we're in those conversations today. I thought we would be ready, but because of some of those delays I just talked about, we need that additional time. Yeah, it's not quite as much money as we asked in the beginning, but as I talked to many of you, we had significant carry forward, and I think we'll have some unspent dollars this time, and we can manage it. $390 million is a lot of money, and we should be able to continue these projects, but we can only do that if we are good stewards of the dollars we have right now. And I think it's sometimes easy when you see dollars that are in an account that you have right now and say, I could do this or I could do that. We got to be very careful right now and make sure that the dollars are used for these key programs as we continue to get approval from the LBB and carry those dollars forward into the next biennium to plug in those holes for your institutions related to TCHAT and the rest of the programs. Alex, let me just double check with you. Anything that you would like to add or that I didn't get quite correct? She's come this way, so there must be something.
No, everything is
Right here.
more or less correct. I would just say that and echo Dr. Lakey that we have set up your budget check-in meetings. So hopefully by then we will actually have more solidified information. I know that some of you are coming up here pretty quick, so if you would be patient with us, I would really appreciate that as we round everything up. But I will be reaching out to you all and providing some more information and some guidance as we go forward.
Yeah, that's good. So again, sorry for the delay. I believe it's really important that we be really transparent with the legislature related to the funds and our plans and have their blessing. There were projects that were continuing with the GR from the UB that were ARPA, and I need to make sure that they don't think that I'm just doing it on my own, that they had the opportunity to say no to me or say yes. And so I don't think there's going to be any issues, but that's the role of the legislature, and we will work with them to make sure that we are moving forward appropriately. Okay. Any questions from anybody?
So Alex, are we gonna have separate meetings for the research networks with you?
No, it will be one budget check-in, but if you would like to have a separate meeting about research, I'm open to that. But we can definitely talk about it at that time.
Jeff and I want to communicate to the nodes about what their individual budget's gonna be, so until we know what the final
Yeah,
budget
once
is,
I know, we
that would be
can.
really helpful to us
Yeah.
if you could reach out.
Yeah, I can
Okay.
do that.
All right. Any other comments or questions? All right, seeing none. Thank you, Alex.
Thank you.
Let's move to Eleni. I'm going to turn my computer over to you for an update on communications.
Sorry, you can have a chair. Good morning, everybody. I just wanted to provide a couple of reminders around communications. The first is that we have some pre-approved presentations available for teams. So we're asking any presentations that teams put together for CPAN, PeriPAN, or TCHAT that you check SharePoint first. The hope is that we just are saving your teams some work. So these are all old presentations that your teams have submitted in the past that have gone through the review and have been approved. So hopefully you can pull from those and use those either as a starting point or use them as they are. If you make any changes to the presentations that are available, we just ask that you do then abide by the 10-day communications policy and submit them for review. But hopefully that would be a quicker process just because they are pulled from pre-existing presentations. If there's something that doesn't meet your need, a topic or the presentation just doesn't work for you, you're still welcome to create your own from scratch. But again, then just adhere to the 10-day policy and submit for review and approval. And then in terms of promoting those presentations, just a reminder that there are templates for flyers and social media, and those all exist in Canva. If you're having any Canva issues, anyone on your team is, or you're not aware of those things, feel free to reach out to us and we can help get access and walk you through sort of how the Canva team works. And those, if you use a template, there's no need to submit for review. So we're just asking that if you create something on your own, you either not and use a template that exists to save you some work, or you submit it to us for review. And then once you do have approval on a presentation, just a reminder that the events page on the consortium website does exist, and we do love to post all of our presentations there. It's just another avenue for promotion. Our CHC team, when they're doing external newsletter content, social media, they like to pull from there and direct people to our events page. It's been pretty slim the last few months, mostly just this executive committee meeting has been on there. So we really want to remind teams to get them out there. It just helps bolster that page, and then also is another avenue for promotion for you all. And then lastly, just a reminder and sort of an update to our internal newsletters that we send out every month for CPAM, PeriPan, and TChat. We always do an employee spotlight, which I think teams have been really liking. We've been enjoying putting them together, but we are now expanding it to allow for an HRI sort of highlight and promotional area. So if there's another team member you want to shout out, if there's the person doing the spotlight, you want to just also add to why they're so great for the team, we're offering that. And then also an opportunity for HRIs to just post an outreach spotlight. So if your team went to a conference and it was great and you've got pictures you want to share, we'd love to put that up on SharePoint and also put it in the newsletter, just in an effort to kind of show all the work that you all are doing and build sort of this team. We're all 12 different institutions, but we're all pushing towards one effort. So that was my rapid fire.
Maybe can I make a quick follow on, just take a minute?
Yep.
There's another agenda item on the data dissemination policy that will be voted on, but I want to kind of emphasize that Laney's in charge of all the presentations, and all presentations must be approved by Laney's operation. And if those presentations include data, then it has to come to the data committee. And there are two processes. I think people have been confused about them. And presentations includes sending an abstract to present at a meeting. So we've had some issues lately where people have sent in abstracts saying they're going to do X, Y, or Z, and then calling and asking, well, now I need to get this approved. And it's unclear, are they simply doing a kind of qualitative description of consortium projects, in which case it just needs to be approved by communications, or are they wanting to present data? Either they want to request data from Trait, from Kosh, or they've got their own data locally that they want to number crunch and present. That needs to come to the data committee, and it needs to be enough time so that the data committee can do its due diligence to say, yes, this is approved to present. And I'm getting a little worried. We're going to have situations where we're going to be telling people they can't present at the meeting because they didn't go through the process or there was some problem in their process. So it's very important to tell all your faculty, all the people working on your projects, they shouldn't just open a website, send in something to present at a meeting, and then say, well, I'll ask permission later. Because that may not work out. And we'll have a little more time for discussion when we present the data dissemination policy.
Dr. Wakefield?
Yes, Dr. Pliska, I appreciate that. And I just wanted to say that I think that will be happening probably in the near future, a little bit more than the further future, because some of the submissions, especially for this ACAP coming up, happened before we had official guidance related to this and before the policy was solidified and codified. And so I think that I just want to give credence to, I think there's a little bit of confusion, people saying, well, you should have known to do this, but really the submissions were done before we had a codified policy in the data, at least, and for presentation. So hopefully now the policy is very clear. And then my question was for to make sure we can direct our faculty and they don't just have to wait on us. Where is that policy housed on the website, or is it in SharePoint, Nagla?
The general communications policy exists in SharePoint.
Well, the policies that we approved a couple of meetings ago about how to go through data and then communications, are both of those in SharePoint, and just wanting to make sure some people have difficulty getting into SharePoint, like our faculty, especially if they're not in there all the time. And so just trying to figure out where these policies, just to making sure I'm clear on where the policies are so that we can direct our faculty to there and they don't just, so we can make it clear.
The Data Dissemination and Publication Committee and the policies associated with publication, those are what we're going to be presenting a little bit later, Dr. Pliska, and we'll be voting on those, and we'll make sure to clarify and maybe even consider putting something together to kind of allow you to know how to navigate the different components and where the policies are. So we'll clarify all those.
Thank you. I guess I saw them before. I was thinking we had already voted on them. I didn't realize we were doing that today. So yes, I think there is some confusion because those aren't hard, haven't been out there. But hopefully with the new policies and knowing how to navigate to them and making that clear for our faculty, then this will become a non-issue in the future.
Yeah, we pushed the vote to today because there were some comments, and we'll address those in a few minutes. Thank you.
All right. Any questions for Lainey? If not, thank you, Lainey. Ashley, let me bring you up. We have a series of policies that we're going to be talking through today. Many of them have been presented before, and then we've gotten feedback and they've been re-edited. So again, we want to make sure that they meet your needs, but we have 4 different policies that we're going to go through. And let me turn it over to Ashley.
Good morning, all. I will quickly highlight the 2 policies that you will be voting on today and any changes that have been made since our May EC meeting. The first policy applies to all consortium programming and overviews the policy governance process. Next slide. Okay. As a reminder, this was previously a TCHAT policy that was adapted to be applicable for all programming and overviews the process for policy creation. It highlights issue identification, the steps for policy development and implementation, the process and timelines for reviewing policies, and the various deliverables. Next slide. The only revision to the governance policy was an update to the definition of medical director, and this was just to ensure consistency with the rest of our consortium policy documents. Next slide. Here's the expected timeline, highlighting the key steps along the way. If the policy is approved today, it will be fully implemented. Does anyone have any questions about the governance policy?
All right, any further discussion? If not, I'll take a motion to approve the policy.
So moved.
So moved from Dr. Nemroff. Do I have a second?
Second.
Second, from Dr. Pliska. Any further discussion? Hearing none, all in favor of approving the Texas Child Mental Health Care Consortium Programs Policy Governance Policy, signify by saying aye.
Aye.
Opposed, nay. Did anybody abstain? So then let the record show we had unanimous approval of that policy, and let's move to the next one.
All right, the second policy applies to CPAN and PeriPAN and overviews the psychiatry shift roles and cross HRI coverage. Next slide, please. This policy documents expectations that had previously been agreed upon but not formally documented for psychiatry shift roles and coverage for CPAN, PeriPAN phone consultations from other HRIs. It covers topics such as the psychiatrist's role while on shift, expectations for requesting coverage support due to vacation, illness, or current consultation, incidences in which an HRI may need to request coverage of another HRI, and the process for requesting this coverage. Next slide. Since the May meeting, there was an update that was made to the policy to indicate that if coverage is needed, COSH may assign an HRI based on review of the coverage calendar to ensure adequate staffing and coverage of calls across the state. Next slide. And here's the expected timeline for the coverage policy, highlighting the key steps along the way. If the policy is approved today, it will be fully implemented, and COSH will begin providing implementation support. Any questions on the CPAN PeriPAN coverage policy?
All right. Hearing no questions, do I have a motion to approve the CPAN psychiatric shift role coverage policy?
Move approval.
Move approval from Dr. Wagner.
Yes.
Okay. Have a second?
Second.
Second from Dr. Ibrahim. Any further discussion? Hearing none, all in favor of approving this policy signify by saying aye.
Aye.
Opposed, nay. Did anybody abstain? Let the record show we had unanimous approval for this policy. Now let me turn the podium over to Rachel and Nagla for the data dissemination policy.
We have two data-related agenda items today. This is a new introduction to a new policy. This policy, which you all received last week, a copy of sets forth requirements and guidelines for the dissemination of consortium data and data reports. It covers data dashboards, data reports, and access to and dissemination of data. I mentioned this is a new policy, so I'll just run over very quickly just at a high level some of the expectations here. So UT System is going to be providing each HRI with data dashboards, measures, and reports on a regular basis. Our internal and external evaluation teams have been and will continue to prepare these deliverables. UT System and program medical directors / program hubs will incorporate these data into discussions with HRIs. Designated individuals within each HRI will have access to the dashboards and reports. That we will be limiting access, though, just as a good general practice measure. Request to share the dashboards and reports outside of the HRI, we're asking that those be submitted to UT System. UT System and our evaluation teams will have access to all of the dashboards and reports, and medical directors and program hubs, including Kosh, will have access to the dashboards and reports that they for the programs that they oversee. HRIs will only have access to their HRIs data and statewide data, but permission is required if an HRI's data will be shared with another HRI. So here's the timeline and where we are right now. We prepared the policy, got HRI feedback, and we're introducing it to you all today. And of course, there will be time now for any questions. In between this meeting and the next meeting, we will solicit additional feedback from you all before an expected vote in September. Any questions on the data dissemination policy? The next policy is our CPW policy. This is also a new policy. And the policy covers work group membership and roles, and the CPW medical director role, guidelines around rotation sites, including eligibility, new partnerships, non-compete with other HRIs, and ending partnerships, and expectations around services and administration. I mentioned this is a new policy. However, most of these expectations have been discussed and decided upon with CPW workgroup members. So I'm not going to go over all of the expectations in the policy, but you all do have a copy of that. Here's the timeline. Again, we prepared the policy, got an HRI feedback. We're introducing it to you all today. There will be an opportunity for feedback between now and our next meeting, and we hope to get a vote in September. Any questions?
What's right? The whole now or later.
Stay there. Stay there.
Okay. Are we doing the CPW program update?
Yeah.
Okay. Yeah. So I don't need to.
Okay. So thanks, everyone. Thanks, Rachel, for going through these governance documents, which I think are really important. And appreciate the time of everyone to put them together, your time to review and to discuss here and to approve. We try to make sure that we vet them here, take your feedback, improve upon them, and bring them then the next time for approval. So with that, let's transition to item 8 on the agenda and the update of the various programs. And let's start off, Dr. Pliska, with the CPW program.
All right, very good. The CPW programs at all the various HRIs continue to progress really well. We are showing really a very robust clinical programs at each site. Significant numbers of patients being seen in a wide variety of different settings. We'd worked with HHSC to look at our data collection from the LMHAs, which is an automated process, and we cleared up some difficulties around that, and the numbers that are coming through now look much more realistic. That is, they correspond fairly closely to what the HRI's expectations are for the number of patients that the resident and faculty have seen. In the policy that you're looking at, really it's a very broad policy to guide the work group. That really is the place where any issues about how the CPW program operates are resolved. The general idea being it's a community-facing, patient-facing project, serving people who are principally underserved, low-income folks. And I think all of the programs that people are doing kind of meet that criteria very easily. So there have not been any major issues. The one thing is, coming into the new biennium, there are questions from sites that they would like to expand. I think the question there is, did they put that money in their budget request? In which case they should bring that up in their budget meetings. But people obviously should not commit to an expansion unless they clearly know the funds will be forthcoming. But other than that, I don't have any other major updates.
Very good. Any questions for Dr. Pliska? Hearing none, Dr. Brenner, let me bring you up to the front here and give us an update on the CAP fellowships.
Thank you, Dr. Lakey. Well, excited to be able to share with you what has been the first phase of my efforts in this role. Let's go to the next slide. So this is material that's already been presented at TCMHCC and basically illustrates that the TCMHCC has been incredibly impactful in increasing the number of child and adolescent psychiatry fellows in Texas. This is especially impressive because people may or may not be familiar, but nationally, 30 to 40% of child psychiatry spots around the country don't fill. That's not been the case in Texas. So even with this increase, our child and adolescent psychiatry program directors have been really deserve an enormous shout out because they've been doing an incredible job of actually expanding slots and filling them. Next slide. As in this first phase of my efforts, I've been having individual meetings with the CAP program directors listed here. Next slide. And what I've really been interested in thinking with the group about is the following. The growth has been impressive, but I don't think that any of us think that we're close to where we need to be in terms of statewide saturation or distribution of child psychiatrists. So questions that we talked about in these individual meetings were, what limits further growth? Is further recruitment a concern? Is the pipeline a concern? And the second question, are there specific places where statewide collaboration in program activities would add value? And then what are some specific points of pride for each of these programs that we can celebrate? So the big picture is that recruitment, as I said, has been very successful in Texas, but it remains a concern for the CAP PDs, especially when considering further growth. So even with success, some have said that we're always worried about filling. There's the anxiety of a zero-sum game that we're competing against each other if we don't increase the pipeline of folks who are coming into child psychiatry or increase the medical students who are interested in coming to Texas. And most important is the middle point, that medical student debt is a very big problem. And it does have an impact on medical students and residents' choices of future trajectories and specialties. And currently, medical students and then general psychiatry residents don't see fellowship, child and psychiatry fellowship, as making a difference in their future compensation. They're largely accurate about this. So unlike other specialty fellowships and subspecialty training in other specialties, our child psychiatrists don't get to see a commensurate increase financially. And this is a problem for recruiting. Next. Encouragingly, people had a lot of really productive ways of thinking about what to do about this as we talked individually. Insufficient compensation, also the degree to which the fellows need to be taking on-call service can be a deterrent to recruiting. In general, in psychiatry, in all residency training, you come out of medical school and the first couple of years in your specialty are where the heavy call is. We're asking something significant of people to do that, finish their general psychiatry, then return to then go on to child psychiatry and return to heavy call commitments. So that is an issue. People had ideas about how we could do some programming to increase interest in child psychiatry during medical school. So not waiting until they're already in general psychiatry residencies. In general psychiatry residencies, a number of people brought up the idea that what kind of exposure they get to child psychiatry during general psychiatry makes a difference. And finally, an idea that I found very interesting, the idea that we lose some amount of Texas medical students to general psychiatry in programs outside of Texas. And perhaps we could focus on that group as a cohort to recruit back for child psychiatry. Next. Next slide. I'll go through this very quickly. There are other things that people brought up that were potential limitations to further growth of their programs. One that was surprising to me was the difficulty finding inpatient psychiatry sites for rotations. The number of faculty and retention of faculty was cited by a number of child program directors. And then the issue of having particular areas of faculty expertise that are hard to fill and that are required for child psychiatry training. Next slide. Which last point brings us to the question of what could we do statewide that would add value? And virtually everyone who I spoke with individually thought that some sort of collaboration on didactics would be of use to them. One quote, "We've made it work, but providing all the didactics is difficult. Statewide didactics would be awesome." And a number of people pointed that there are specific required areas that are hard to find expertise in every program: forensics, addictions, psychotherapy, and government advocacy. Next. I asked people what they thought the strengths of their program were when they're doing the recruiting. And it was really quite exciting and a privilege to hear about some of the things that are happening around the state. Texas Tech El Paso has created a rural child psychiatry track that is really quite innovative, and I think it's been very successful in drawing some terrific people to their program. Several programs, including Dale and UT Southwestern, have created community tracks. UT Dell protects time for psychotherapy patients in their curriculum. I think that that's a very promising thing to do. A lot of medical students today come into psychiatry with the hope that they'll be able to integrate some aspect of psychosocial treatment into their care of patients. Baylor has a innovative curriculum where their first year is in outpatient, so it allows them to put an emphasis on seeing many patients and developing interview skills. UT San Antonio has a very strong tradition of faculty devotion to teaching, including current and former chairs and chiefs of child psychiatry. UT Health Houston shared with me how they've been able to add a number of sites on particular areas that are really quite popular among residents, like eating disorders and developmental pediatrics, and that's happened through TCMHCC funding. Next slide. So the next step, which actually happened yesterday, day before, was to bring together the child program directors for a shared meeting. So we met a few days ago. I'll have more to say about this in future slides, but it was a wonderful discussion. People first felt that for many of them, they'd not met or seen many of their colleagues around the state. So there was enthusiasm about the idea that this was an opportunity to create a sense of community and again of child program directors being on the same team, trying to work towards the same statewide goal. There was a lot of enthusiasm for, I think, the project that people saw as the low-hanging fruit that we could immediately make an impact in is creating some shared didactics. And so I asked for volunteers to form a work group about this and was very excited. For any of you who have ever asked for volunteers at the end of a meeting, 5 minutes after I had gotten the emails from people, so quite encouraging. We'll form a work group and begin to explore this. And I think that's it.
Yeah, take the slides down, and then I think we can have kind of a general conversation here. Charlie, I see you're raising your hand.
Yeah, well, that's really terrific, Adam. And Dr. Newport may want to weigh in, but we've been experimenting with research track residents who then go into child and are creating, Jeff can speak to this, a pathway they can continue on the research track in child psychiatry. And I just wondered if that's something that you might consider expanding. Jeff, you want to comment? It's not been easy because of the time limit.
We're actually putting together a proposal to do that at UT Southwestern as well. So I would love to talk about how to collaborate in that and how to find some synergy in those kinds of efforts.
Yeah, I would love to meet with you to discuss there's sort of two populations, those who have come through our own residency and then fast track into the fellowship. And we actually have someone doing it this year. And so we'll have some experience. What we haven't yet figured out is if we recruit a fellow from outside who's only going to be doing the fellowship with us, is there adequate elective time to build in a research track for those? I'm not sure about that.
We are planning to put together a 6-year program for that, to recruit somebody in at the beginning. So I'd love to show you what we're thinking of and see what you're doing.
Yeah,
thank you.
Yeah, let's definitely confirm.
Right.
And we at El Paso, the general psychiatry residency has done this, and so then either this year or next year, we're going to start the same thing in child too. So I'd love to hear from everybody how it's going at other places.
Great, we'll include you.
Thank you.
Any other comments? Well, first, thank you, Adam, for pulling this together and your leadership in this. One thing that Andy.
It was a
Yeah,
small side comment, but I just think everybody should just feel extremely proud of this. I mean, this is such a huge thing. And I think particularly the success rates in place, folks, I'm so glad, Adam, that or Dr. Brown, that you're thinking about this. I just want to say that our eventual goal, I think, should be that we switch things around so the general residency actually is a child residency, and then people have to get specially trained in adults, since these are pediatric illnesses. So let's not keep that eventual goal. Let's make sure we're looking at that, because that's where we eventually need to be, and Texas should be the first ones to do that.
Dr. Keller, I would like to talk to you more about that. In fact, the general psychiatry program requirements will be coming up for revision in the next year, and a number of us are advocating for a much more robust inclusion of adolescent training in general psychiatry. So I'd like to talk to you.
So one thing that Adam and I discussed briefly this week, and a lot of it is in light of the disasters that have taken place in the state of Texas and the flooding, et cetera, and thoughts, and Trina, would love your thoughts related to this, but wondering if there's an opportunity to collaborate across our institutions related to the education training we're providing our fellows related to disaster mental health. If there would be value of figuring out what the core competencies, core kind of curriculum would be across the state, so that if somebody's trained at various universities, there's the same level of competence related to disaster mental health. Adam, did I get that right?
Yes, absolutely. And I'm grateful I want to give credit to one of our young faculty at UT Southwestern, Kaylee Davis-Bordowski, who brought this to me as a proposal with the idea that we should think about some kind of standardization so that when DSHS and TCMHCC call for volunteers, that we can have some confidence that our trainees have all been trained in a certain up to a certain standard.
Okay. And I think Trina has been bumped out as a technical issue, so she may join us in a little bit, but I think it'd be good to get her input. But Sarah?
Hi, yes, in October, we have a new faculty member starting who did the disaster psychiatry fellowship at Walter Reed. He was one of my colleagues from when I was in the Army, so I know that he would have a lot to offer there.
Okay. Would you please send him my way?
I sure will.
Yeah. So I guess maybe as a next step, Adam, if folks at the variety of institutions have somebody that is really competent in that area, a lot of experience, if they could send their names to you, and then we can think through kind of what collaborative related to disaster mental health would look like.
Thank you very much.
Okay, very good. Dr. Wakefield, we're going to go next to you related to the Perry-Pan update.
All right. Can everybody hear me?
We can.
Okay, great. It's such a privilege to get started on Dr. Williams' slide, but I feel underprepared to discuss her meme or cartoon, but it's very cute. And so maybe we should all try to do more nothing for a little while, but I think we're all very busy doing lots of something. So thank you for the reminder, Dr. Williams. Next slide. Keep on trucking. There we go. Okay. Perry-Pan enrollment. So we'd just like to give an update. I actually will ask Jen, just so that I remember to do this, that I think we should show this as a graph function instead of in a bullet point list like this in the future. But I think it is important to show how many we've been following all of the different clinicians that are enrolled in Perry-Pan, but our metric continues to be focused on the obstetric clinicians, or OB-GYNs. And so we have 1,200 and this continues to climb, which we're very excited about. Next slide. And here is our typical data slide. We've had some decrease in May and June from our peak call volume in April, which we were really excited about. Those April numbers. Our May and June numbers are not, I mean, they're still elevated. We would like them to be higher, but I think one of the differences is in CPAN, we really expect a seasonality, just like we do in our child and adolescent psychiatry clinics, where we have high volume during the mid-fall and mid-spring, and then we have these dips. We're not quite sure what to expect with our perinatal population, And so we're continuing to watch those trends. So is this, I guess what I'm not sure is this a dip because there are less people coming to appointments just like there are in child psychiatry, or people are happier in the summer, or what is happening? I'm not sure, but we'll continue to watch these trends. And our hope is that we can help as many clinicians as possible in Texas and that our numbers continue to increase over time. So that's something we will watch. Next slide. I think it has more data on each of these things. Yes. So total consultations by month and calendar year. So you can see, which is exciting, that we have overall higher volume than we've had in the past. And even this lower number during June is higher than any number of last year. So overall, our call volume continues to increase, and we are excited about that. We have Jen has put these great points in here, but just to remind everybody, we started PeriPan as a pilot with only 4 health-related institutions, and then we did a statewide launch with all 12 health-related institutions. So we have seen call volume, of course, increase as we've expanded across the state. When we look at let's see, I think next slide. Yes, here we go. So PeriPan consultations by type. I think this is better, or it's better for my brain than the previous slide with the data points, or with those little data points in the right-hand corner. This is a more clear explanation of that. But when we look at consultation by type, we are always thinking about what the percentage that goes to psychiatry, and why we think about that percentage is that the data from other programs across the country or more mature programs demonstrates that it is the clinician to clinician discussion between the psychiatrist and the obstetric clinician that shows the difference. And we'll talk about direct consults in just a second, but that shows the change behavior or the increased capacity for that frontline clinician. So typically, when we look at other states, we expect typically about 33%, a third of calls will go to psychiatry. So anything above 33%, we're really excited about. So you can look at, over the last 3 months, we have had all in PeriPan significantly more than 33% of calls have gone to our psychiatrist. And we hope to continue that increased number so that we can provide as much expansion of capacity to those frontline clinicians as possible. Though for the non-psychiatry, there's still a lot of resource and referral and some education happening there too with our behavioral health specialist and the calling clinician. But it is, in that discussion with the psychiatrist that we have demonstrated the change behavior. So we're excited to see those percentages so high. Next slide. So this is our direct consultations by month. You could see, again, we had our highest point in April. We expect that our direct patient consultations will follow the trends of our consultation numbers in general. And so we have seen some decrease in those, or significant decrease in those in May and June, or really June was a much lower number. We will continue to follow this trend and watch and see what happens, and why this is so important is that in the data and the evidence base from other states, we see change, or specifically from PAP for Moms, we see change behavior happen in that clinician to clinician discussion, and then additional capacity building in that direct patient consultation and that follow-up discussion between the clinician or the psychiatrist and the obstetric clinician, because the obstetric clinician can really compare what they saw in the patient to what the psychiatrist saw in the patient, and then have some learning in there about what was the same and what was different. So confirm some of their hypotheses, and then question those other ones and really help build that capacity and the expertise. Next slide. This has been a question over time, and so we have continued to include this slide. This is the what type of physician. Physicians continue to be our highest caller when we're looking at different specialties and different expertise or roles. And then when we dig down and look at what type of physician, our obstetric clinicians, our OB-GYNs, are our highest call volume. followed by pediatricians, then psychiatrists, then family medicine practitioners. We think just to talk about this other data, I'll talk about those 4 points and then we can talk about these other bars in here. It has been interesting. We have been discussing that we're really excited to provide general psychiatrists more perinatal expertise. We know that general psychiatrists get very little exposure to perinatal psychiatry, reproductive psychiatry in training. There have been several studies done about this in the past, and one showing that they got on average of 6 hours in their entire training exposure to perinatal or reproductive psychiatry, which is very interesting, thinking about all of that women tend to present for mental health care more frequently than men. So how many women they'll be taken care of over the lifespan of their clinical lifespan. So we want to really increase that expertise. And when we look at our webinars and our residency curriculum, and we'll talk more about that, that is a really big focus, is providing opportunities for general psychiatrists in training to get more exposure and expertise in perinatal and reproductive psychiatry. But what's most interesting to me about this data is that our family medicine doctors are calling less often than our psychiatrists. This may be that a lot of family medicine doctors across the country, across the state, are not participating in obstetric care as much as our OB-GYN colleagues. But I would expect this number to be higher, thinking of family medicine doctors, especially in West Texas and other rural places that are doing significant obstetric care. And then the family medicine doctors who are taking care of new babies and interacting with moms and screening. So that has been a source of discussion amongst our team recently, and how we can partner with our family medicine colleagues and make sure that they are aware that this program exists and is here to support them. And then I wanted to talk about the resident. We're really excited about how many residents our colleagues in training are calling. We are in a future trait update, we will have more specificity in what type of resident is calling. And our goal then is to really show that among these categories and divide them and show you what type of residents, what clinical specificity of the resident is calling. And additionally, with that medical director, I know this number is really low, the 2%, but we're making some changes so that we can delineate what specialty that medical director is and put those in the appropriate categories. Next slide. So pathways, we're participating in a PCORI project with Lifeline for Moms, called Pathways. We've discussed this several times in the executive committee, but just as a reminder and as information for those of you who are newer to our committee, this is a project that is based on a previous study done in Massachusetts that showed if we really provided more guidance within the clinic about when to screen, what screens to use, how to respond to those screens, that we could increase not only the call volume, but also really support that clinic, that obstetric clinic, in providing the current standards of care. That many times the standards of care are put out and they have existed for quite some time about what screens to use and how often to screen, but many clinics don't have that built into their workflow, and so are not doing that, or are screening and don't know where to refer mom to. So really working with those clinics and building that expertise. The goal is to build the expertise within PeriPan so that we can provide that guidance to clinics. Like, this is how you build this in. We're here to help you know when to screen, who to screen, at what point in pregnancy and postpartum periods, and how to follow that up and what to do next. So this is the PCORI with Lifeline is beyond Texas. There are many, many states involved, many states that have perinatal access projects. But we in Texas have the most sites that we compared to the other states. So we're really excited about that. 7 Texas obstetric clinics are actively progressing through this process. We have the potential for 7 more. And so we're happy to have those conversations if there are other clinics across Texas that are interested in participating in this. through this process, we hope to build the expertise so that PeriPan can actually deliver this expertise and this service to any clinic that would be desiring additional support in how and when to screen and what to do next. Next slide. So we just wanted to shout out actually how everyone is working together. This has been really fantastic. We have identified some rural clinics and some urban clinics. We are really excited to have this UT Health East Texas Women's Services at Four Seasons in Tyler as the latest clinic to show interest in the pathway study. And there's just a lot of excitement and collaboration. And so wanted to show that we're still enrolling people, and it can be lots of different types of clinics across the state. Next slide. We wanted to show this quote from Dr. Willis, who was the latest obstetric clinician who wanted to participate in Pathways. But I thought it was really important to just demonstrate why she was interested in participating in this program, because she's found so much value in PeriPan. And this was really meaningful to all of us, and wanted to remind everybody that we show all this data, but this is really what we are doing, and this is the point of our access projects. So Dr. Willis says, I'm so very grateful for PeriPan and all its resources. My first encounter was when I had a postpartum patient who became suicidal after the birth of her fourth child. I picked up the phone and called PeriPan. What I received was like a fairy godmother with a magic wand. PeriPan was such a blessing to this patient and her family at one of the most vulnerable times. I am grateful beyond words. I want to remind everybody is that PeriPan's there to support the clinician. So what PeriPan actually did was support Dr. Willis in evidence-based standards and what resources exist in Texas. And then we were able to work together collaboratively to get this patient the resources she needed. And it is very exciting. So thought this was our team thought it's a great time to remind us what we're doing here and why. And it's not just about one more call or call volume or all of those things, which are important because it's how we reach more clinicians and help more women. But this quote was really meaningful to us, so we wanted to share it. Next slide.
Sarah, can I just add, Dr. Willis is fantastic, and she was recently named the chair of women's health at our institution, and I think she's going to be a fabulous champion for the program in our system moving forward.
Thank you. And thank you, Brittany. We are, you have been such a pleasure and a support to us in this process in connecting with Dr. Willis. So thank you for that. It is so exciting. You know, when I think about the collective experience of responding to the disasters in the state, or just how we come together to do the right thing for women in Texas, to support them in this very difficult time, or what can be a very difficult time. We want it to be a very joyful time, is really exciting, and such a privilege to do this work and reach out and work together. Wanted to remind everybody we are continuing our ECHO and webinar resources and education. One is coming up on August 5th, care coordination with midwives, doulas, and other specialty care providers. Again, trying to look across all of how we collaborate together to support women in Texas and through this journey of the pregnant postpartum period. Next slide. This is our calendar for our collective PeriPan and Be Well ECHO series. Just as a reminder, we're working together with Be Well Texas. It's been a phenomenal collaboration to really look at how we think about not only what we might traditionally think of mental health care, but also substance use disorders in the pregnant and postpartum periods. When we remind us, and a very sobering fact, that suicide and overdose are two of the leading causes in the first year postpartum. And so we joined with Be Well Texas, really focused on treatment for substance use disorders and support and education for clinicians, much like we are for perinatal mental health care. We joined forces to deliver an integrated curriculum about perinatal mental health and substance use disorders in this ECHO model, where we are able to provide some didactic information and then a case presentation and discussion with many experts. We have addiction psychiatrists and other experts. We have perinatal mental health experts, all on these ECHOs. So they are fantastic to join. Please recommend them and disseminate this to your faculty, to your residents, to your trainees, to your fellows. This is a really exciting educational opportunity that I don't think exists like this anywhere else in the state. In the country. I know it doesn't exist anywhere else in the state, but in the country either. Next slide. And this is our webinar series. So we have a webinar and an ECHO each month. They are linked in the topic content. So the webinar precedes the ECHO by a couple of weeks. And then the ECHO is the deeper dive and the case-based discussion linked to that webinar topic with more experts on the call. Dr. Lakey, I saw you light up. Did you have something you wanted to say, or was it just?
Nope, go ahead.
Okay.
Nothing.
No worries. Next slide. All right, looks like CPAN. I will say before we go into CPAN that what we don't have a slide on here for, and I can get anyone who would like this information more details, that so whatever residents or trainees, fellows attend the webinar series, Jen Erdigy sends out an offer to attend a resident-based office hours that have multiple perinatal experts on those office hours. The residents join. There are board-related questions because we think that's what the residents are really interested in, but then a lot of facilitated discussion to provide that training as well in what we hope is a less intimidating environment with other experts or faculty on that call as well. And so that happens once a month. And all you have to do is just get your residents to attend the webinar, and then we will follow up with them when they register and show that they're training.
All right, very good. Thank you, Dr. Wakefield. Let's transition. Dr. Williams, go through the data for CPAN.
Yes, happily. I'm not feeling my best, so hopefully I can do an okay job today. So we just want to talk about some of the projects that are in progress. We are working to launch our statewide CME as a reference point. Prior to this biennium year, each of the HRIs kind of had their own series and in different capacities, and we're finding that there's just it was so successful for PeriPen to have just a statewide group of CMEs that we sort of went and adopted that process, and we're working through that as we speak. We will have both the webinar and then an alternating project ECHO throughout the entire year. All of your team members across the state are currently either creating the slide decks, some or the reviewers and eventual people who will be the presenters. And we are also working on having the webinars become continue things that you can go and look at again in the future. That's been something that PCPs have asked for. Could I go back and watch it and still get CME? So we're working on that as well. The launch for our first of the statewide CMEs for CPAN is coming up in a couple of weeks. The other thing that we've been doing is obviously working on sort of the launch for that PCP portal. This is again going to be yet another way for PCPs across the state to be able to access the consultation. It is not an asynchronous consultation, so let me be clear. The point and the purpose of this is to allow for the PCP to potentially, if they prefer, instead of a call or a text, ask for help, they can put it in through the portal. We think this will help a lot of times, as everybody's aware. PCPs will often be doing their documentation into the evening, into the night. I actually heard somebody call it pajama time for physicians. So this might be an opportunity. Hey, I'm in my chart. I remembered I needed some help with this young person or this woman. I can go in real quick and put my question in, and then the next business day, the CPAN or PeriPan team would sort of help that PCP. It also will allow for us to send the materials in a secure platform. And eventually it also will help with sort of the consult summary. So we're really excited. The beta launch, because it's such a big sort of process, we don't want to just launch statewide. So we will have a beta launch that will be probably late August, with a couple of our providers across the state who've agreed to participate in the beta launch and get some additional feedback before we sort of set the sort of final launch date for the entire state. We are still working on sort of the improvement to calling on behalf of. It is not an insignificant amount of time that the PCP may ask somebody else in their office to start the consultation. And so we want to be more able to clearly delineate how that process flow, both for our team and for the provider, and eventually also for our evaluator teams for the data. We are also working to sort of update our PCP data lists. As you know, people will come into the state of Texas, move out, retire, all those things. So sort of keeping our PCP sort of known universe list up to date is not a small task. And the IE team is sort of helping Kosh organize what that should look like, provide the sort of rubrics, definitions that the teams need to follow in order to do that vetting process. So we're working on that right now. We also, back to sort of the issue of how we keep track of our referrals that resources for referrals that we have. We've been using this, the data platform Wellneti for that purpose. We'll be working obviously with Dr. Lakey's team to sort of be able to follow the legislature in regards to asking for that resource database list. But we're excited that we already have something that exists, so we don't have to be starting from scratch, and we'll be having more information about that moving forward. Currently, Wellneti has mostly been used by the CPAN team, but we have also introduced it to TChat. They're different programs, and they themselves have different needs. So we're working to make sure that utilization of the platform will work best for both the access program teams as well as the TChat team. We will sort of have a user work group. So our end users, our team members that are involved day to day in doing the consultations, have some suggestions that they've had sort of help their workflow be improved. So we'll be working with them in the fall to kind of specifically delineate what those improvements could be. Again, walk that through our entire process before we make those changes. And then finally, obviously, we use a phone telecommunications company, Lantana, and there are also some ideas for some workflow improvements that we'll be working with our Lantana vendor on. So a couple of things are happening. Our CPAN consultation volume, as you can see here, we've had a steady sort of state with our call volume. Even for the month of June, it did drop as we expect always in the summer, but not necessarily in too much of a significant way. It is obviously still significantly higher than it even was last year, the total consult volume. We're still getting the calls in well within that metric that we've set for ourselves at minimum 90% of the time. It currently sits at 98.6% of the time. We're getting the call back if a PCP asks for the call back in 30 minutes. They don't always ask for that. Next slide. This is, again, becoming a very busy slide, but we still think it's valuable, to Dr. Wakefield's point, that you can just sort of see the growth from year to year. The top line obviously is the line of the year that we're in right now. And as you can see, again, we've continued to have growth. I do actually expect us to continue to grow, but what that will look like, Dr. Lakey, I know you've asked before, are we at a steady state, yes or no? I still don't think we're at a steady state as far as volume, but we are still pleased to see the growth from year to year. Next slide. And so Dr. Wakefield's point earlier about we keep track of how often the psychiatrist is involved in the consultations. And for CPAN, it has been sort of more consistently a slightly lower amount than the PeriPAN access line, but it still is sort of hitting above that 33% mark as far as the involvement of our psychiatrists in the consultations. Next slide. This is our direct patient consultations by month. So this is just the ones that are actually completed. We do have a number of ones that they may get started. For example, the PCP may say, yes, I would like the consultation. And then we may not be able to reach the family or the woman, or we do reach them and they say yes, but then they, for various reasons don't complete the consultation. So this number does not represent all the work that our teams are doing, but it is sort of the amount that is our final. When you start to add up all the hours that it takes to do a direct patient consultation for our team, it just from the psychiatry side of things, not even the other team members, we're kind of at the rate that it's almost 1 FTE per month of our psychiatry team members that are involved with doing directs. And so we're excited to see that number grow. Again, summer is you're aware, is just a slower time for child mental health. You'll see similar numbers when we look at TChat in a minute. Next slide. That's all I had for CPAN. I will say, are we going to move to Safety A? Is that why it went away? Maybe. Because the slides went away.
Yeah, why don't we go ahead and move the Safety A, and then we can go back to TChat.
That's fine. I just wanted to introduce Dr. Pincinati, who's going to be talking about our statewide Safety A program.
All right,
Dr.
very good.
Pincinati has done an amazing job.
Thank you. Yes, I'm Caitlin Pinciotti. I have been leading the Safety A effort here from Baylor, and we're wanting to just provide some updates on how what we're terming phase 2 expansion is going. Next slide. So I know this information has been presented before, but just to kind of level set, the information that we gathered during our pilot phase has been really helpful and kind of informed how we've approached the subsequent expansion phase. So in our pilot phase, we trained 68 primary care providers. And then we asked them questions about the feasibility and acceptability, both of the training process as well as the Safety A intervention itself. PCPs were overall very satisfied with the training. However, we had some difficulty getting PCPs to be able to attend all 5 of our training sessions. So PCPs attended an average of 3.5 out of the 5 training sessions, but we had only 29% who were able to attend all 5 due to time constraints. In terms of feasibility and acceptability of the intervention, we had a majority of our PCPs who completed our surveys indicating that they had used Safety A at least once in the 6 months that we collected data. And the average number of uses of Safety A was about 7 per PCP, with a pretty wide range. So we had some PCPs who used it just once in 6 months, and then others who used it up to 26 times. And so altogether, that amounted to 288 total uses of Safety A over the 6 months that we collected data. But we did find when we asked PCPs about the different kind of specific components of the Safety A intervention, that they most commonly endorsed insufficient time as being the largest barrier to using all of the Safety A methods. Next slide. An exciting update is that we published these outcomes recently. This paper came out just within the last couple of months, and it was selected to be highlighted by APA Division 53. That's the Society of Clinical Child and Adolescent Psychology on their social media platforms this month. So that's really exciting news. Next slide. But based on what we learned about PCP's perspectives on feasibility and acceptability, we made several changes to the training process. As I said, the training schedule was not feasible for most PCPs. And so what we have done is we now offer a tiered training approach where PCPs who aren't able to commit to the full 7.5-hour competency training over 5 training sessions can still receive some Safety A training. So we have level 1, which is a pre-recorded just 1-hour presentation, really kind of getting people's feet wet, hopefully getting them interested in Safety A so that they'll want to sign up for one of our full trainings. Level 2 would be just attending the 3-hour master training, and then level 3 is the standard Safety A training process, which is 7.5 hours over the course of 5 training sessions. We also have been offering monthly, or at least monthly, suicide risk assessment trainings. These are 1-hour live trainings, and soon we'll be moving these to pre-recorded as well. In terms of the feedback about how it's not feasible to use all components of the safety A intervention for every single patient. Our approach to this is just to continue to emphasize the necessary adaptations of safety A for primary care settings as opposed to emergency department or mental health settings. And really emphasizing during our trainings that there is no one size fits all, that it really isn't necessary to use every single component if it's not relevant or helpful for the patient in front of you. There also was a need to scale up, and we've done several things in the service of this. So the first thing that we did in phase 2 was start to develop our own trainers. So we're not relying on the safety aid developers at the ASAP Center to always lead these trainings for us. So starting around this time last summer, we started holding what's called Train the Trainer, and we got and moved towards training our own trainers to lead these. There's also a need to enlist CPAN in the Train the Trainer, develop a recurring schedule of safety aid trainings to be made available for PCPs, and then get all HRIs involved, since we had about half who were involved in the pilot phase. Next slide. So looking at these by the numbers so far, the level 1, that 1 hour pre-recorded kind of intro to safety A, we've had 82 PCPs registered, but just 5 completed. So we are working on trying to sort out what might be going on there. Our level 2 training, our first level 2 master training, is being offered this Friday, which is exciting. And then we'll offer those on a monthly basis. For level 3, we were able to simultaneously get our folks from CPAN trained as trainers while also training PCPs in the process, which is really great. And so during those cohorts, we had 42 PCPs who attended the master training, but again, only 3 who completed the full training course. So this is really suggesting to us that most PCPs will probably be more interested in level 2 versus level 3. And as far as Train the Trainer, we trained 9 trainers, and 8 of those are still with us, which is wonderful. We also have developed the schedule of monthly trainings through August of 2027. I have an asterisk here because this is subject to change based on need. We can add more, we can combine some. We're planning to just sort of monitor this and see what the flow is. And for the suicide risk assessment trainings that we've been offering, we've had 167 PCPs attend these over the course of 11 trainings. Next slide. So I'm kind of considering now what we're moving into as phase 3, which is the dissemination phase, where we really need to, now that we have kind of the process in place, we need to make sure that PCPs are aware of these opportunities and that we're getting as many folks trained as we can. And so the first goal is to disseminate these recurring training opportunities to PCPs across the state of Texas. This includes recruiting both from primary care clinics as well as from residency programs. If there are residency programs who want to involve a safety aid training as part of their kind of standard training, that would be wonderful for them and for us. And as a reminder, we use PCPs loosely. This is kind of any provider in a primary care setting. So if there are nurses or other folks who also want to attend training, it's available for everyone. As I said, we'll be analyzing attendance patterns and making adjustments to our schedule as needed, while also emphasizing that we can offer individualized training dates. So if a clinic or a residency program wanted a specific date that wasn't one of our predetermined offerings, we can definitely work with that. And really just having all hands on deck for recruitment. So our team of HRIs has been phenomenal in getting the word out and keeping this going. And now we're seeing this as sort of a kind of statewide lift. Oh, sorry, I wasn't done with that one yet. We also need to maintain a pool of safety A trainers who are in good standing. So as I said, right now we still have 8 safety A trainers, but we can offer additional train the trainer cohorts as needed. For now, we're sort of holding on that because we're not entirely sure what the need and request for these trainings will be. And 8 seems like a really good starting point for us. We'll also be looking soon at how to train all of CPAN staff in Safety A, so that if a PCP calls and they need help kind of being walked through using the Safety A intervention, our staff can support them with that. And then lastly, we've been working closely with the Safety A developers and some of our other collaborators as well to create, and then ultimately we'll disseminate a best practices guidelines for PCPs who are not yet trained in Safety A. So if you haven't yet gotten Safety A training, what is sort of the next best thing in terms of approach for suicidality? Next slide. And so, and I'll let Dr. Williams also join in if there are other key discussion points that you want to add. But I think the 2 main discussion points for us to sort through is how can we maintain a really effective and continuous dissemination of Safety A and the suicide risk assessment training across the state, and how do we get residency programs involved in our training offerings.
All right. Dr. Wakefield, I see your hand.
Yes, I just wanted to say that we have for the past 2 years had our residents, as they are entering as part of a boot camp, do the 3-hour training, and just to give them make sure that they have a general understanding of safety assessment, risk assessment, and safety planning. And it has been excellently received. And I have noticed a significant difference in very quickly residents being more evidence-based in their risk assessment and safety planning. Dr. Mitchell, I don't know if you want to say anything to that about your experience, but I would encourage that utilization as well.
Yes, I love that idea and the discussion point to try to include residency programs and training programs broadly. I think it's fantastic opportunity.
Thank you for that. I'm glad to hear it. I know Dr. Vincenti and the team have been working very hard. Dr. Lakey's always in my ear around this one. We need to do trainings that make sense for our busy providers across the state. And so having variety of the different levels, we do think is going to be a really good strategy. I anticipate that the teams that will do the longer training might be like a whole team decides to do it in a clinic or an organization. But being able to do the 1-hour risk assessment of the 3-hour Safety A training itself, I think that we'll probably see that's the biggest one. We definitely want to partner with PCPs, but also with the residency groups. So all the pediatrics, family medicine, psychiatry, child psychiatry residencies. We are definitely working with the HRIs because that's how we can get this information disseminated out. And hopefully we'll have a steady a number of people on a monthly basis from all those different categories who are, engaging in some form of training in suicide risk assessment and safety planning. So great work. Okay, T-chat. This will be reasonably short, I think. Not any longer than the CPAN one. Next slide. So projects in process. We are working with the UT system team, as you may or may not be aware, on the intermediate services. Those were initially called the ARPA programs that have been folded in. So that is substance, anxiety, and trauma. And so those processes are getting finalized for review. All the teams will be reviewing them. And one of the things that's going to be critical about the intermediate services is that if an HRI themselves cannot possibly provide that service, being able to link them to another one of our HRIs, because again, the work that we're doing in TChat is virtual. So we certainly could have a family who could participate across the state with one of our other HRIs. So that's one of the biggest pieces, is making sure we have a good connection, and we do that relatively seamlessly if the decision is that an intermediate service may be useful for the family, they agree to it, and then we could transfer them over to the other HRI. Obviously, all the teams are working very hard to prepare for the upcoming school year, which is for most of us just a couple of weeks away. So they've been going to back to school events, doing trainings, getting everybody kind of up to speed for that. We have been updating, revising training materials for our team members as the TChat teams have continued to grow and get larger. The need for us to make sure that they understand sort of not just how to use Trait, but how to use sort of the other things like SharePoint, because we've had that conversation come up today as well, but just really making sure we're coordinating that process of training so that people can utilize our systems correctly and make sure that we have a good data integrity. We certainly continue to do training and support for HRIs that as they have new team members join their programs. Sorry, again, a little bit tired because I'm not feeling well. Additionally, we've had some additional trainings on very specific intervention models, brief intervention models for different kinds of evidence-based social interventions. One of the things that we are working on that you may be hearing more about is around presentations. Again, we want to make sure that we're working collaboratively, but also cohesively and within sort of the framework of TChat. And so we're working to sort of potentially develop a policy that would be sort of what are the sort of presentations that TChat as a team, as an organization for the state should be involved in. That process is obviously a collaboration. And so your teams will probably hear more of that. We've had our first couple of work group meetings around this, and we'll continue to refine that. It may end up becoming a policy that at that point would obviously come to the executive committee for review. As I said, at the CPAN one, we are working around the utilization of WellNeti specifically for TChat. Again, these are different programs. They do run differently, but given that we've been asked to sort of share our resource referral list to the state, we see value in potentially, making sure that our TChat team also has a process in which we can keep track of their resources that they're sending. So that's the projects that are in process. Next slide. Again, this should look very familiar to you as there continues to be a growth year to year. And we continue to see the summer slide as everybody moves off to doing a couple of things, vacations, remediations, all those kinds of things that make it such that we don't see as many kids during the summer. Next slide. That being said, we do obviously still have TChat is open for business all summer long. We do not close our doors, even if the schools are closed. Again, virtual care continues, but as you can see, the numbers, despite the fact that we do get more enrollment than we did the first couple of years, we still see a much smaller number of families who join into their sessions. Next slide. And then this is just sort of looking at the overall total number of treatment sessions from month to month, with the red line being the actual number of students. So when you look at the red line for June of 2025 versus the red line for June of 2024, and there is a little bit more students, but still, as I said, there's not as many students in the summer. Next slide. And then this is the same slide you've seen all along. We continue to see that the vast majority of the students that are served are being provided a psychosocial intervention by one of our therapists. And that's it.
All right. Any questions for Dr. Williams? All right. Seeing none, thank you. Again, thank you and the rest of the team for all the work. Rachel has a presentation related to the governor's report.
I'll just really quickly go over the first few slides of our governor's report that focuses on expansion statewide. One important update is that we now have more recent data thanks to our internal evaluation team.
and our transition to Salesforce, which all the HRI TChat teams have been part of. So thank you all. And we think that having access to more recent data will really be beneficial to us. So as of June, you'll see that we're active in 77% of schools, and that represents 80% of the student population. We saw 9 HRIs increase their active campuses in the last report. Number of schools with onboarding dates here. And ESCs, we saw six ESCs increase their active campus count, and that number of active campuses increased by 37. See here that growth continues on the upward trajectory. And the main reason for declining continues to be that there are existing mental health services. Any questions?
All right, thank you very much. So we have about 4 more items. I know we're kind of in that lunch period, but we're going to power through. I would ask people to be concise, possibly, to make sure we get through as quickly as we can, because again, I apologize again for the technical challenges we had at the beginning. They kind of put us a little bit delayed, more than we have been in the past. But Dr. Pliska, let me turn it over to you for the data committee governance and members.
Okay. So we are, I believe, voting this to establish the Data Dissemination and Publication Committee. So we have the next slide. There is the policy, which we discussed earlier. And these changes are here. I won't go through them one by one. Let me give a quick, literally back of the envelope overview of the data committee process. So you, as the investigator, you may want to request data from COSH that you want to analyze, or you may have your own data locally that you either already have or want to collect. You will submit forms to the data committee describing what you will do. We will approve that. You do it. You bring the results to us. We say, yes, we agree you did what you said you would do. And then if it's a manuscript, you show us your manuscript, and then you send your manuscript off. If you submit to a meeting, you prepare your poster or your slides. The final step for that will be to go to the communications people to do their part, and then you do it. Some other points here that I want to make is that data committee does not cover either of the research networks. It does not cover NECMR projects unless those projects deal with consortium participants or data. And finally, we may have faculty or residents who are funded by the consortium who may be doing some kind of research as part of that role. That research would not be approved by the data committee, again, unless it directly involves the consortium, or in some way you're going to say to your funder you were sponsored by the consortium. In that case, it would come under the review. All right. So with that, could I have the next slide? Do we actually have the list of the members? You want to show that?
Don't need to approve first the document.
Okay, so the first step is to approve the policy itself.
So let's go ahead and see if there's any questions related to the policy itself before we talk about the actual members. Any questions, any comments? Peter, Dr. Thompson?
Yeah, great, thanks. This is going to be a hugely important committee for the consortium, and I just like to see if the policy can reflect that the committee reports to the executive committee on a regular basis their activity.
Okay, I have a friendly amendment to say that the committee reports to the executive committee. Okay, we can add a sentence related to that. Any other comments? Hearing none, can I have a motion to approve the Data Dissemination and Publication Committee governance document?
I can move it.
I have a motion by Dr. Raji, a second by Dr. Nimroff. Any further conversation? Hearing none, all in favor, signify by saying aye.
Aye. Aye.
Aye.
Opposed, nay? Did anybody abstain? Let the record show we had unanimous approval of that document. Okay, Dr.
So now, the following individuals have volunteered to be on the committee and have been approved by the chairs at their respective institutions we're asking approval and a block vote for all of these individuals. Is there one slide or two you want to show everybody?
There's another slide for the nonprofit, but we're starting
Oh,
first
oh,
with the.
okay. These are the members who come from the HRIs. And one key point is these people are not representing their HRI. They are on the committee because of their role and their expertise to look at all of the proposals that come to them.
Okay. Any comments? Okay, and again, we have one vacant position. We can add another individual. I'd like that other individual to be from a non-UT institution to make sure we're well balanced. But this will be the initial slate of individuals for this committee.
That the committee can vote for the last vacant position.
Yeah.
So
And-
not
and-
have to wait till the next.
And then,
meeting.
and this committee we're gonna give the authority to this committee to vote on the last vacant position. So any further discussion? Hearing none, do I have a motion to approve this slate of members?
So moved.
So moved from Dr. Nimroff,
I second.
second from Dr. Raji. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed, nay? Any abstain? Let the record show that these members were unanimously approved and they were given the authority to add the additional member. And Dr. Plitzka is the chair. All right, if we can go to the next slide.
And this is the nominee representing the nonprofits, Dr. Coley from the Meadows Mental Health Policy Institute.
So we need to, we've made this nomination. Any further discussion? Take a motion to approve.
Move to approve.
Move from approve from Dr. Farmer. Do I have a second?
Second.
A second from Dr. Ibrahim. Further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed, nay? Did anyone abstain? Let the record show that we had unanimous approval for Dr. Coley, representing the Meadows Mental Health Policy Institute.
And just to note, I'll be reaching out to all the members to set up a standing monthly meeting. One we could always cancel if we don't have proposals to review, but we want to get a good head of steam going so that as people submit, we respond to them in a very timely manner. We don't have to spend a lot of time scheduling ad hoc meetings.
All right, very good. Thank you, Dr. Plitzka, for your work. And Nagla and the rest of the team for putting that together. We'll now transition to the CPAN TChat logic models.
Thank you. Since this is to provide an update on the CPAN and TChat logic models that we presented at the last executive committee meeting. And since the last committee meeting, we reviewed and made updates to these program logic models. No changes were requested to the CPAN logic model, which is shown here. And then the next one for the TChat logic model, we made a few updates based on the feedback that we received. Just briefly, we made some updates to the goal statement, and then we also made some wording changes throughout the model to be more intentional about the use of mental health versus behavioral health. So all feedback received and all of the updates are documented in a change summary table that we can provide if needed. And that's pretty much all the updates from the last meeting and from the review. So, and thank you all for your review.
Thank you, Dr. Pliskin, to you and your team for putting this together. Let me slide over here to a second. Any further discussion for either of the logic models? Everyone's had a chance to review it, and again, appreciate the team taking that feedback and making adjustments. But any further comments? Hearing none. First, the CPAN model. Can I have a motion to approve the CPAN logic model?
So moved.
I have a motion by Dr. Plitzka, a second by Dr. Nimroff. Further discussion? Hearing none. All in favor, signify by saying aye.
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 Opposed, nay. Did anyone abstain? Let the record show we had unanimous approval. Second item, approve the TChat logic model. And have a motion.
So moved.
And then Dr.
So
Farmer.
moved.
Very good. Any further discussion? Hearing none, all in favor of approving the TChat logic model, signify by saying aye.
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 Opposed, nay. Anybody abstain? Let the record show we had unanimous approval for that for both of the logic models. Very good. Next, we will transition to the quality improvement performance measures, and Dr. Lopez.
Hello, everyone. So similar to the logic models, at the last executive committee meeting, we presented draft performance and results measures for your review. Following the meeting, those went out for any additional comments that HRIs had in addition to previous opportunities for comment, and we did not receive any. So those performance and results measures have not been updated since the last time you saw them. That's it.
All right.
Questions?
So everyone's had a chance to look through them, and we asked for feedback, but did not receive any modifications. And so let's first go to the, so we have three, right? The PeriPan, CPAN, and TChat. The CPAN logic model, any comments? Hearing none, do I have a motion to approve?
So moved.
So move from Dr. Wagner. Second.
Second.
Okay, and who was that? Oh,
Second.
so okay, Dr. Olvera. Any further discussion? Hearing none, all in favor of approving the CPAN logic or quality improvement performance measure, signify by saying aye.
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 Opposed, nay. Anybody abstain? Let the record show we had unanimous approval. Next, we'll go to the PeriPan quality improvement performance measures. Please take a quick look. And I'll take a motion to approve.
Approve.
I have a motion from Dr. Nimroff. Do I have a second?
Second.
Second from Dr. Plitzka. Any further discussion? All in favor of approving the PeriPan quality improvement performance measures, signify by saying aye.
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 Opposed, nay. Anyone abstain? Let the record show we had unanimous approval. Finally, the TChat quality improvement performance measures. Take a look at it, and I'll take a motion to approve.
Approve.
I have a motion from Dr. Wagner,
Second.
a second from Dr. Ibrahim. Any further discussion? Hearing none, all in favor, signify by saying aye.
Aye.
Aye. Aye.
Opposed, nay. Did anyone abstain? Again, let the record show that we had unanimous approval. Very good. Thank you all. And thank you, Dr. Lopez, for all the work and putting that together and everyone that was a part of that. Last act of business for today. Now I'm going to turn it over to you for the update on the new and emerging child mental health research grant.
Okay. Thanks, Dr. Blakey. So as mentioned before, we're still waiting on a final approval of the budget. And what that means is that we right now don't know if the budget would be the 6 million or what we had last year, the 8.5 million. So I'm going to first go through what the process for the review was, what the process for selection is. And based on that, what we wanted to do today is not present the actual um, accepted proposals. We want to wait until we find out. We're thinking that we're going to be finding out by Wednesday, whether it's the 6 or the 8.5, because based on that, we will know how many we can include. So let me first go through the review process. All the applications we received went through this review. Each one received 2 external reviewers. So these are reviewers from out of state who reviewed and who were matched up based on their expertise that aligned with the application as much as we could. The state also reviewed. We had 3 leaders from representing HHSC and the Texas Council of Community Centers go ahead and look at those applications, assessing them for Texas priority. We had also 3 high-level reviews. What that meant is that the external reviewers from out of state would look at those and just look at the abstracts and look at the training and the ability for these proposals to move into an R01. And the reason we had this is because we did group reviews that included 5 external reviewers. So to have that discussion, we had 3 of them do a high-level review. So each group review, we had 2 group reviews, had 6 to 8 reviewers. It had 5 external out-of-state reviewers, and it had between 1 or 2 participating in that group review state reviewers. And what they did is they reviewed each application and gave it a kind of an assessment of whether they felt like it was an excellent application and should be moved forward as a finalist. They identified whether it was a good proposal and should be a backup. That means if we have sufficient budget, we would go to those backups. They did kind of rate them as a lower level or a higher level or just a backup. And then finally, the final identification was whether they felt it was not competitive and should not be moved forward. So the process of selection, as we looked at all the reviews that were done and the group review, is we wanted to include all applications that received an excellent rating. That means that everybody, through a consensus, made a decision that this should be moved forward. And then after that, we looked at any institution without an excellent rating. We want to make sure that all institutions participate in this process, at least with 1 candidate. And so what we did is we started looking at the backups, and for those institutions who had the highest scoring to move forward as far as being a backup. And then if an institution did not have any excellent or backup, a consideration was made for those that were identified as not moving forward. What every single reviewer did is they actually reviewed fully and added comments about what changes would help to make this methodology for the research more sound and more effective. And so what we want to do then, if an institution did not get an excellent or a backup, is choose and select one of the highest scores, and from the ones that were told not to move forward, and incorporate those comments and have them resubmit kind of those pieces where they can kind of move it forward. Other things that we kind of wanted to look at then is any backups, even for institutions that we've already identified, just to reach up to whatever the maximum amount of dollars that we have. And so then we start looking at that. And then other considerations that we had in our notice of funding opportunity is that we didn't want any institutions to receive more than any one institution to receive more than 20% of the total funds. And so we would look at that. And then the combination of funds of any university system would not exceed 70%. So for example, the University of Texas system, so all the different institutions added up together should not be exceeding 70%. And then we've received a lot of suggestions from the reviewers, and we want to continue to improve the process. And so these are some of the suggestions. Require additional mentorship. So this time around, we went ahead in the NOFO and provided mentorship from across our HRIs, some volunteers that we had that could provide mentorship to any institution. And I think, you know, there was suggestions to provide more mentorship. One of the suggestion and one of the things we realized is we really need more lead time. And so we would like to start earlier in the year or the year before in order to kind of ready the applicants and make sure that they are also, they have mentorships and support as they're submitting. We're thinking about a potential in-person summit or something similar to showcase posters and past grants awardees to allow future applicants to kind of understand and see what's happening and to make connections with potential partners, mentors, and state agencies. We also want to provide more strategies of successful grant applications and how to also be successful in completing their projects. And then more specific instructions on applications. For instance, on our abstracts, many of our applicants did not really incorporate all the pieces that you would want to see in an abstract. Which for those reviewers who only looked at the abstracts had a hard time finding those pieces. And so,
you know, let me
go
jump
ahead.
in here,
Yeah.
maybe. So first, it's been a lot of work, and I want to thank Nagla for all the work in putting this together. And so coordinating the review committees, the developing the NOFO, sending it out, all the reviews. Yeah, again, it's been a lot of work, but we were pleased with the number of applicants and the quality of the applicants that came in. I think a lot of desire, especially in the current environment, to be able to invest in young individuals, help people move projects forward. I had hoped today we would bring to you the slate of individuals, but because of the final budget isn't approved, as we discussed earlier, I'm not sure if I have $6 million or if we have $8.5 million to invest. And the reason we had 8.5 last time is that there were some unused dollars that we were able to pull together and move it to that level. And our hope is that we're at the same level of individuals we're going to be able to fund. But I don't know that till next week. And I didn't want to come to this committee and have like two tiers of people that we're going to approve, and have the tier that we approve today and then a second tier of individuals that we approve the next day. I'd rather just do it all at once. And so, you know, we've had a research advisory group. I talked to them about it, kind of went through in detail, make sure that they were comfortable with the process. The feedback I got, that we got, was that people were very comfortable with the process. And how the selections would be made. But again, want to do this at once. I will say that every institution that had somebody submit a grant, there's somebody at your institution that's going to get a grant. Okay, and we wanted, it was not going to went through, tried to be very objective with the peer review process, also making sure that we're fair across the systems. And so actually, can we put that language back up? Okay. So we have proposed language that the executive committee give me the ability to make a decision on the awarding of these NECMR grants based on the criteria that was presented after the LBB approves our budget. And so if they tell me I have $6 million, I have a set of individuals that I can move forward. If it says that I have $8.5 million, then I can move forward on that. The awarded more proposals we placed on our website by hopefully by the end of next week, as soon as we get the LBB approval. And so I'm asking that you give us the authority to be able to move forward once I know what that final amount of money is. And so I'm happy. I have a motion by Dr. Nimroff.
My second.
Second by Dr. Raji. Any further discussion? Hearing none. All in favor of the proposal with the proposed language that I just read signify by saying aye.
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 Opposed, nay. Did anybody abstain? Hearing none, let the record show that we had unanimous approval.
David, I did want to say that a shout out to Naga and the team, because the rigor that these grants were reviewed is as good or better than any NIH committee. And the quality of the reviews, the feedback that are given to the applicants, so they might reapply if they don't make the mark, is just extraordinary. And it's a ton of work.
It's a ton of work. I would also say, thanks to your help, the reviewers are heavyweights.
These
These are leaders in the field. Yeah.
Right.
A lot of experience doing NIH reviews. And so, yeah, thank you. Olga, I see your hand.
Hello, just quick clarification question on the LBB guidance, Dr. Leakey. It's going to be a biennium guidance, right? So first we'll work on our 26 budget, and then we'll work on our 27 budget.
It's a biennial budget, and so we put both years in it, and so they'll give us the amount of money that we have for the biennium in each of the programs.
Okay, and then after that is when we'll finalize our 26 budgets.
Yeah. Yep, Alex is setting up meetings with everybody to talk through that. And so, as we told folks at the beginning of the meeting, be careful with the money that's in your budget right now. We need to be very careful that we use it for the essential services, because those are the dollars that allow us to continue these essential services through the next biennium. Okay.
Thank you, Dr. Leakey.
Yep, thank you. Any further comments or discussion? All right. Hearing none, again, thank you for your time. I apologize for the technical delays we had at the beginning. So I'm sure you guys are ready for lunch. And so with no further ado, thank you. And see you in the meeting. Let's adjourn.
Thank you.
Thank you.
Bye, thank you.
Bye.
Bye.